Hi everyone. Hello. So, we're going to talk about external fixators for trauma. The difference between an X-fix for trauma and an X-fix for definitive treatment is that you're looking more at the practicality of it than how robust it is, how long it can last, and how safe it is for the patient to walk on and all those things. So you don't need X-fix with pins coming from every possible plane and make it as rigid as possible. You want something that works and serves a purpose, which is to protect the limb, provide some kind of immobilization, like the perfect splint, for example, giving you access to any wounds, and not interfering with your definitive treatment. I'll prepare the content in really short notice, so if you think that there are questions that I haven't answered, please feel free to ask, interrupt, or in the end, I'm happy to. So, the basic X-fix is the X-fix of a single long bone. Okay, you can put a single rod and pins. You need at least two on either side of the injury, of the fracture. The difficult way is to put a single rod and pins through one rod, or if it's a curved bone like the femur, or you're not after an absolute anatomical reduction, you can build two different blocks and connect them with a pin, so you can adjust and reduce under X-ray whenever you want. All you need to know is the safe zones. So, for example, this is a tibia. Imagine these are axial slices. And if you notice, you have like a radius throughout the whole tibia from the front to the medial border. Okay, that's the fibula, that's the medial border. So in mainly every plane. So you can put a pin from anterior to posterior up to medial to lateral in any line between those two. Okay, and you're not interfering with any muscle or anything like that. So it's easy in the tibia. That applies for any bone. You need a safe zone to put your pin through. Ideally, you don't want any vessel or nerve to be in the way, okay, obviously, but ideally you don't want any muscle or tendon to be in the way, because when they move, they will shear, they will start either pulling the pins or fall apart because the pin is stronger. We prefer to do pins front to back in the tibia, like that, and usually we use cut 3 and 4, that's mid-shaft. Any way you do an X-fix in the tibia, you'll probably need to do those pins. Okay. Now, you know the near-far configuration for an X-fix. Okay, you know ways to make the X-fix stronger. I won't stay in that. Another optional way for the tibia is to do this. 2 denim pins, very simple X-fix, very unstable. It leaves the sagittal plane free to move, but it leaves the whole tibia intact. Can you imagine why this would be useful? As opposed to putting 2 pins in the proximal tibia and 2 pins in the distal tibia for a mid-shaft fracture.
Temporizing measure before plating.
Yeah? So you don't have any pin sites where your plate will be. Yeah, that's one. Anything else?
For major soft tissue defect, where you want things anterior.
You leave it alone, yes. So this use of the X-fix is for stabilizing the fracture. What other use could the X-fix have?
Reduction of evil.
Yes, exactly. So you can use this X-fix and do a nail without removing it. Can you see? You are actually, that's the denim pin at the top. And if you put it posterior enough, you can do the entry point of the nail without interfering with the pin. And you leave the whole shaft intact. You can use it so you can do a single-handed nailing just by using the existing X-fix. You can easily prep and drape over it, so you have the whole tibia in front of you without having to remove it. So that's a thing to consider. Now, for single bone X-fixes, it becomes more complex when it comes to the upper limb. You almost never do an X-fix in the humerus for trauma. Almost never. Why I'm saying almost never? Because a splint will do a great job, any brace, or just a sling might do the job. Sometimes you have to cross the elbow though, you have to stabilize the elbow by putting pins in the humerus and the ulna or the radius. So you need to know the safe zones in the humerus, which are a bit more complex. And why are they more complex, you think?
Radial nerve.
Radial nerve that has a, it's not a single plane, it doesn't follow a straight track, it spirals around the, so at every level the position of the nerve changes. You can track it there if you can see. So I suppose that it's somewhere, where is it? There, right? Somewhere there when you're close to the elbow, it's almost lateral.
Yeah.
But when you're, let's say, here, it's safe to go through the delta and go in the humerus or here. And the nerve goes lateral, more anterior, and it's completely anterior here. So you have to consider the height where you are. In these situations, when you want to avoid a structure that you don't know exactly where it is, you can do a pin in an open fashion. You can do a 1 to 2 centimeter incision, dissect gently down to bone, and then do your pin. Okay, that's a safe way. Like you pin supracondylar fractures in children. The medial wire, you always do it under direct pain, right? You can do an X-fix this way as well. It's safe. That's usually for the humerus and for the distal radius, where you have this superficial branch of the radial nerve and you want to avoid it. It's better to do like a 2-3 centimeter incision and do both pins through that incision and then close the space between them in the end. The X-fix that you do for trauma in 90% of the cases is the ankle spanning X-fix. Okay, I'm sure you've all done one. Any features, I mean the people who work at the Royal London might recognize this configuration. So can someone describe it and tell me why we're putting the pins where we put them? I mean, you've all done them. So why are the tibia pins there and not any lower?
To be away from the area of fixation, of definitive fixation.
Exactly. There's the zone of injury around here, if it's a pilon fracture for example. If we fix it with plates and screws, the plates and screws might go up to here and down to there. And our pins are away from the zone of fixation, not the zone of injury, away from the zone of fixation. So no interference between pin tracks and future definitive treatment. Why are we using this?
Prevent it from crossing into equinus.
Okay, and why do we put it in the metatarsal? It's on the first metatarsal, okay. Why don't we put it, let's say, more proximal? Or in the talus to avoid equinus? Or why is not this denim pin enough to hold the equinus? Since the Achilles tendon is pulling the calf, right? And you fix the calf with that pin.
Too close to the center of rotation at the junction.
Lever arm provided by a distal.
Is the Achilles tendon the only flexor of the foot? So you have Achilles, you have tib post, you have the long toe flexors. So they all have attachments distal to the midfoot. The toe flexors, okay, might give you curly toes, it's not such a big deal. But tib post, that its last insertion is in the base of the first, second, third metatarsal, will give you what we call a midfoot break. So you might get the heel at the right level and then get a midfoot break. And again, if this stays on for weeks, it's very hard to reconstitute. And the patient will have a heel complex pilon fracture and will complain that they cannot walk because their foot is in cables. Okay, so there's a reason for everything. And most importantly, do you guys recognize this? We love this. Okay, we love this here. The kickstand. So keeps the heel off the bed because the leg feels very heavy when you have an X-fix on. I haven't had one on. I had a plaster and it felt very heavy. I imagine this feels even heavier. And also you don't get heel ulcers, and if you have soft tissue repairs, you can monitor your soft tissues without having to just elevate. And so in cases like this one, this is a complex distal tibia fracture with loss. This is a free flap. We couldn't put anything in the hindfoot. I think we put 2 pins in the forefoot. Anyway, you can see that you can monitor your whole flap without having to elevate, and you don't risk the integrity of your flat. So this, the ankle X-fix is your basic X-fix for trauma. It's 90% of the X-fix is that. Now, when you want to span the knee, there are two schools of thought. You create a block in the femur, block in the tibia, and you connect the two blocks. Now, how many of you like to do it all anterior? And how many of you like to do it like lateral femoral pins and anterior tibia pins? Which one do you prefer? Okay, who prefers that one? Defend yourselves. So why that one and not this one? That's what I'm saying.
So
Yeah.
well, for me, I'd be less scared doing a lateral
Okay. What
with minimum invasive approach, and I can be confident that I'm not going to have any major nerves investments lateral.
like?
So I'd be worried that I'm going to hit from the femoris coming anteriorly, or
It's more medially, right?
yeah.
It's anterior.
But I mean, I think that's safe as well, but I prefer to do that way.
Okay.
Find a choice.
I mean, it's easier, right? And it's more. It's the first thing that comes to mind. Like we're doing a femur. 99% of our incisions in the femur and our approaches are lateral, right? So, who wants to defend this one? Go.
It's because if we put it lateral, the patient will have tough time on the bed, in the ward.
Yeah.
He will always be having this problem, so we'll have to put on another pillow and might have some ulcers in the lateral.
They cannot roll.
Yeah, they cannot roll.
But you can put another rod and stop it to roll back.
Of course. Yeah, but then you fix the patient on the bed, right?
Well, the patient already going to be fixed with that fracture.
Yeah. Okay. That's patient's comfort is one big thing. What structure do you go through when you put them lateral to medial?
Process naturalis.
Or yes?
ITB.
Or ITB. ITB, if you injure it, is not that completely benign thing. They might have from just pain, maybe stiffness, to muscle hernias if it's a big incision. It's not completely benign. Okay. Anyway, I prefer this one to be honest, because the only thing that you injure is quadriceps. But if you span the knee, the quadriceps is not moving. So it doesn't shear, it doesn't move on the pins. And there's such a big distance between the skin and the bone that it's protected by a big muscle nerve. It makes me feel better. And it's very comfortable for the patient. Okay, very comfortable for the patient. So they can even sleep on the side. Whereas with this one, it's impossible. And also, which one do you think is more stable?
First.
This is a Z with like a single bar. Yeah, so that's how it usually looks. And that's some added stability. And there are many ways to add stability. So you can do your basic 2 and 2 pins, and then you can cross-link the two bars. You can double stack the bars, so from the same pins you can put another set of bars. You can start crossing stuff. You can put oblique pins like this one, and increase the stability. It gives you so many options. Whereas the lateral and anterior gives you a bit less options. It's not wrong. I'm not saying, and I'm not saying that's how I like it. It's my personal preference. It's not there's no guideline that says do it like that. Now, when you want to span the elbow, you want a neutral position of the elbow. It's usually for dislocations, complex fractures, or soft tissue injuries, like open fractures, because we prefer to fix upper limbs very early. The safe zones are a bit more complex. So if you want to add a couple of tips, the proximal ulna is subcutaneous and it's big, it's safe. Distal ulna is subcutaneous again, but it's not big enough, so you won't get good fixation. Proximal radius, I wouldn't do any half pins in the proximal radius. Okay, distal radius, just be careful for the superficial radial nerve, and you can fix whatever you want. It's a very big bone. It's like almost like a tibia in the distal end. So it's safe. Again, 2 simple blocks and connect them in a simple way. And when you're happy with your position, then start adding stuff to make it more stable. But don't start making it complex from the beginning. Okay, block, connect, under X-ray get your position, and then you can add whatever you want. This is something that used to be very popular even as definitive treatment. It's a nice way to hold the wrist together. Now we use a dorsal bridging plate more frequently. Any idea why this fails as definitive treatment usually? It doesn't maintain the position. No matter how rigid you make it.
It's one plane, maybe.
We have.
Stiffness of the joint.
No, yeah,
So
the thickness
you've
for
got
the
so
bridge.
degrees of movement. And
So,
just the
let's say you manage to make it 100% rigid, doesn't move, nothing moves. It's still not stable and you lose height. Do you know that?
Collapses.
Yeah. How many
Rotation.
joints are between the proximal pins and the distal pins? Like,
Many.
do you remember a thing called viscoelasticity? So you stretch everything, and then with time it becomes loose again, maintaining the same length, right? So no matter how much you stretch it, it will relax at some point. And if you're looking into fine-tuning, you cannot have this. It's controlled and safe and easy, unless you manage to fracture the wound with a carbon, but it's usually possible. And then you can have X fixes even in, like with K wires, in fingers. Okay. And beautiful extras, and then they never move their fingers again. You can have X fixes in pelvises. It doesn't display very well. So that has been largely replaced by pelvic packing, because the X-fix in the pelvis is not a thing that you use for reducing a fracture. It's to reduce the volume of the pelvis. Okay, so you prevent bleeding. That's why you do this. It's not a way to hold the fracture together. So you can do it with those supraacetabular pins or the pins through the iliac wings. They're both very unstable, both have a very high rate of pin site infections and complications, and they don't do a better job than a pelvic binder or pelvic pack. The clot takes a few hours to form. Okay, so if you put a binder on and if necessary do some packing and the bleeding is under control, you don't need it anymore. Okay, if you want to reduce the fracture hole there, you have to fix it. There's no way to hold it with an X-fix. And it can be easy in a skinny patient, very easy. But usually, you have so much bleeding and abdominal injuries that even in a thin person, the abdomen distends a lot. And you might get even pressure ulcers from the bars that were like 7 centimeters away from the abdomen. Like a few hours later, it can be pressing on the abdomen. So it's very unpredictable and poor control. So there is a thing called the infix. Have you ever seen it? You use, instead of half pins, you use the spinal screws, the pedicle screws, and you connect them with a bar, with a spinal rod, but under the skin. So that's a bit safer for infection and all that, but again, it has to be removed. It's a temporary thing. So that's about it from me for trauma X fixes. Do you have any questions? Nothing?
In terms of the spanning X6 for the knee, for the femur, what the initial one that you showed on the left, what do you think, say, the comfortable degrees of flexion for the less degree of flexion you would have with the patient?
For the knee?
For the knee.
I would fix it straight if
Completely
that's the
straight.
default position, unless there's a reason. So if you have a vascular repair that you're protecting, or I don't know, any soft tissue injury, any free flap that's dodgy, okay, you can flex a little bit to protect it, but the default position is straight. Because if the patient ends up with a fixed straight knee, they can at least walk. With a fixed flexed knee, they can't do anything.
But is it not standard teaching you 20-degree flexion to set the ground clearance? Because that short, the flexion.
If you're doing a fusion, you mean, or
Fusion, and even in X-fix, because the medial lateral ligaments with the cam shape
yeah.
are stretched to the maximum, that sort of thing.
Yes, but then you get a capsule contractions at the back if you flex it.
Okay.
And don't forget, it's a temporary measure. It's not a definitive measure. And everything is in a better equilibrium if it's straight.
Okay.
It will be almost impossible to reduce a fracture to help the patient mobilize if you have fixed flexion. It makes life very hard. Anything else?
I like the plaster.
It's not a plaster.
Because within the X-fix,
That's
for two reasons.
okay.
For two reasons. One, if you're going to put the anchor in neutral, does it mean that you don't need the pin to the metatarsal to keep the foot in neutral?
I think you need it. You need, it's not a plaster, it's just bandages.
It's just a bandage, is it?
Yeah, yeah. So that's the way, I mean, I do it this way.
No, I
Actually,
thought it was a plaster.
we submitted it with Osama yesterday. The reason why we do this way is because what we do is we put the pins first, 4 pins, 2 pins in the tibia, a denum pin in the calc, and 1 metatarsal pin. And then you dress everything, wounds, pin sites, everything, wrap it, and then you throw away your bloody gloves and everything, you put a nice drape, and you put the bars very clean and reduce it under X-ray. You don't need to. So you can even do it with non-sterile kit. Just need single pack half pins, you put them on, and then you need, so it looks nice and neat and clean. You can see everything. It makes it very easy to dress big wounds, especially if you have a vac on. It's very hard to do it behind the bars of the X-rays. And also, imagine you have a situation like a major incident. You have a terrorist attack, and you have 50 people coming that need X-fixes. We have 6 kits, 6 sets, right? So you can only do 6 with what we have. So with this, you can just use sterile pins. You need a particle, boom, 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 and use the millions of non-sterile rods and bars and clamps that we have, and we'll have an infinite stock. So I think it makes more sense. It's pretty hard for the nurse to do the first change of dressing.
Yeah, I was
There's
thinking
no
of,
perfect world, right? Anything else?
In the unlikely scenario that you have a humeral fracture and a forearm fracture,
Yeah.
and let's say that you want to use X-fix because it's open or you cannot give them the definitive fixation straight away. Do you spend any time to find the center of rotation around the elbow joint, or you just put the half pins and then
Center of
lock
rotation,
off the elbow joint
Wait,
in order to?
is there any
to fix
problem in the elbow?
No, you put X-fix here and X-fix here,
Spanning.
or like a spanning one.
No, not spanning. You fix them like 2 separate
just fix them
bolts,
like-
humerus and radius. If there's a problem in the elbow,
Yeah.
you connect the 2 blocks, but then you need
Inflexible.
to keep the elbow in one position, right? If it's injured, until you definitively treat it. There are hinged X-fixes, and you can find the center of rotation. If you have, let's say, an elbow dislocation, and you want to treat it in an X-fix, and you want to allow movement, but only in one plane. And you don't want to allow varus valgus rotation, but just flexion and
Just
extension,
one.
for example. Then you can, yes. It's not easy, but you can find it.
Yeah.
What about the pin site care? I mean, the other reason why I like this bandage is that you don't think about pin site infection. But how do you, how long do you leave the pin sites for, the pins for, and how do you ensure that infection risk is minimal if you need it for extended periods?
So it makes me feel a bit safer than the other way, I must say. And if I'm going to do the definitive treatment, let's say in 4 or 5 days, I wouldn't change anything. Especially if it's for trauma. Now, if it's for infection, it's a different issue. And also, if it's a big open injury that the plastics have to look at, in 2 or 3 days, yes, we can do a pin site. So there's no rule. So when we do frames, for example, or long-term X-fixes, the pin site care after the acute phase is once a week,
Okay.
unless there's a reason. But once a week is more than enough. And after a long time, it dries up, so you can even leave them
For
in open air. Yeah.
for how long? How long can you leave an X-fix for?
Depends.
If you have proper pin site care. How
So
long-
the record in our hospital by Mr. Matt Barry is 18 years. Really? He had a frame on, a patient with I saw this with my own eyes. He had a patient with a frame on for 18 years. Maybe this one too. Okay.
So this is the coronal coronal CT image of a knee, showing a tibial plateau fracture extending to the proximal tibia and extending through the tibial spine. From the previous images and the spanning of the knee, it shows that there might be probably a floating knee injury or a knee dislocation that was relocated. So,
Let's say it's not. It's just a
it's
small
not.
X-ray.
Then it's comminuted fracture of the tibial plateau extending to the proximal tibia and the tibial spine, with the tibial X, with the spanning knee X fix on top.
Okay. You have this as well. I don't know why I have this picture on. So let's think, because it's an old slide. Okay. Let's come but I had an extra. Okay, let's stay with this one. So, what's your plan? How are you going to treat it? Remember what we said before.
Yeah. So first thing to be done is the primary survey in the A&E, which is the ATLS, the ABC.
Isolated
second
injury.
is
Isolated injury.
isolated injury. So the priority here takes to the fact that we have to assess the lower limb vascularity. We have to the methods to identify the lower limb vascularity is basically the temperature and the warmth and the capillary the CRT of the lower limb. We can do an ankle brachial index, a pressure index. We can
Okay.
do a CT angiogram.
It's all normal.
Yeah. So once we did all this and it's an isolated injury and we are happy that the vascularity is intact, then we should now plan for reduction of this fact. It's a closed injury.
Yeah, close it.
It's a closed injury. So basically, with this type of injury, it's better to leave on the spanning external fixator for a period of 24 to 48 hours to make sure that the soft tissue swelling is better or is lost, and that the soft tissues are ready for internal fixation. The main priority here is to reduce the joint line and restore the knee joint once more.
Okay, who wants to take over? I'm up to now. So, we're up to anatomical reduction of the joint surface. Come on, so. Yeah, Alex.
The principles that I'd be looking for would be to restore the width and the height of the plateau, and if possible to restore the articular surface anatomically as much as possible.
Do you know any classification for this match?
Classify it according to the Schatzker classification, which describes.
Okay, do you know what type of Schatzker fracture this is? Okay, wait. This one.
So I think it would be
That's medial, that's lateral.
Schatzker 4,
Yeah.
which involves medial plateau.
Okay, so let's go to, how would you treat this fracture?
I would first of all examine the soft tissues and assess what the state of the soft tissues are.
Let's assume that the patient is in a spanning X-fix, so let's assume that it's been 2 weeks and 10 days and the soft tissues are okay for anything you want to do.
So I would use a proximal tibial plate.
Why did you go for like what type of, like we said, you said anatomical reduction of the joint, and what type of stability, let's say? You want to bridge the fragments? Do you want to fix them robustly? Do you want to connect them to the shaft in any way, or do you just want to span the fracture?
So given the level of comminution, I think it'd be difficult to fix the articular surface rigidly. So my primary aim would be to elevate the articular surface as much as possible. And in order to maintain that reduction, I may need some long screws, potentially with the addition of bone graft to fill any void or cavity. And then a medial plate, the aim of that is to buttress the medial fragment.
Great.
To prevent any loss of height.
Okay. That's pretty straightforward because I don't think there are many more options. So this was done, and reduction, as you said, buttressing, as you said, and a few screws, as you said. So happy that we followed your plan.
Yes.
Okay. Let's do something with more options now. Okay. So let me check first. Who's going to do the exam? I know you, but you spoke. Yeah. So this is a 25-year-old who fell from the first floor and had this isolated injury, no past medical history. And you have this 3D CT scan. I'm skipping the first stage of X-rays. What we do. I'm assuming that if you have a fracture that you are not happy with the imaging, you'll ask for a CT scan. I want to focus on the principles of definitive treatment now. Okay. So how would you treat this?
So your aims of surgery will be to restore the length, alignment and rotation of the femur. It's a comminuted fracture involving the metaphysis and the distal diaphysis. So given the level of comminution, you want to achieve relative stability rather than absolute stability. And this can be done either with a locking plate or I think intramedullary nailing would be difficult given the number of pieces, and also there's very short distal fragments, so the distal purchase would not be
So you prefer a
optimal.
plate?
So I think I'd do a plate now.
Would you open everything to the plate?
I think if I can get a satisfactory reduction closed, I would try to do it using the minimally invasive technique, starting distally and then sliding the plate proximally.
Great. Happy? Fine. So, what I'm saying is that this way of thinking, so you saw that you left all the options, you've mentioned the implant that you're going to use last, so you can achieve that with a nail or a plate. Plate is easier, at least in my hand. So that's a responsible answer, if you want to know that. Okay. And again, in order to do many cases, I'm skipping the first stage of, I know all of you will ask if the patient is alive, if the patient can breathe, and if the patient has any other injuries, and if you just have an X-ray of a complex fracture, you'll ask for a CT scan. Okay. Now, Mr. Parker. No. Who wants to take this one?
I was about to go, actually. I might stay. Get some ankle.
Yeah. So.
Assuming this patient has had, as I said, ATLS treatment and is stable, neurovascular intact leg. This is a closed injury, I assume, or is it an open injury?
Closed.
Is it a closed injury? My initial aim to get a simple close reduction in the emergency department following this.
Would you would you take the patient to theatre, or would you do it as quickly as possible?
I'll do it as quickly as possible. If I got an adequate reduction closed, then and the neurovascular intact is good.
Is that an emergency or this injury, as you see it?
It's a fracture dislocation, so it is an emergency. It's
Okay.
infected.
First attempt. Happy?
No. So,
Second attempt. Happy?
So, two inadequate attempts of the close reduction failed, and therefore I would have a large threshold to take this patient theatre to restore the ankle mortise.
Yeah. So that's what they did. They took the patient to theatre
With a spanning
and then managed to, spanning head, so they managed to put them in a plaster because it was stable after reducing it. So, what do we do now?
So the options are here. Essentially, you want to ensure that the soft tissue is amenable to the primary goal of the reduction. Or you want to ensure that the joint anatomy, joint lining is reduced. In order to do that, you have your options of treatment is closed with a plaster, which would be inadequate in this case because it's an unstable injury. And then we'll consider fixation. So
Do you need any more information, or are you happy with what you have?
I would get further imaging. CT scan.
Okay.
Shows this is a triangular fracture with a significant posterior membrane component. So, depending on soft tissues, whether they're minimal, you could aim to get primary fixation.
Okay. After 5 days, you're ready. So what would you do next?
So my aim is to get anatomical fixation, rigid fixation, and restore the ankle joint, I would joint go exactly well through each segment of each
Would you fix everything? Would you leave something? Would you fix the posterior malleolus?
I think it's big enough to fix them. I think there's the old thinking of if it's less than a third or less than 40 you want.
Mr. Parker? I can see your face. I can feel your face.
Yeah. The artery in my head's gone.
Okay, just because it's going to stay like as information. It's an intraarticular fragment, so you might think of fixing it, and it's also might cause instability.
Yeah.
There's another reason to fix it. Okay, regardless of the size, if the ankle is unstable, and if it's a unreduced weight-bearing surface, okay, that's a reason to fix. Now, let me show you. I won't go into more detail in that. Some real discussion groups from the AO courses, where we can all participate and disagree and debate and all that stuff. 1 second, find a good one. So, that's the information you have. Does anyone remember the AO classification and how to classify fractures without knowing it by heart? Okay, that's the best thing, because you can. That's one of the good things in long bones with the AO classification. You can assume the classification. You can, start 1, 2, 3, a number, a letter. Okay.
Number.
Let's go.
3.
3C.
Then 3, so it's distal femur.
Is it distal?
It's 3, 2.
3 2 C.
So,
3
two numbers, a letter and a number. Okay.
Okay, so 3, 2. 3, 2. E1.
Okay, nice. So anyway, isolated injury, ATLS. Okay, how do you fix that?
So it's
Okay, you have spoken. Who hasn't spoken? Yeah.
George.
George, Morales, go.
Options for fixation would be either an intramedullary main retrograde.
What do you want to achieve? What do you want to do?
So first, I would like to achieve anatomical reduction, and I would like to have primary healing if I can, so compression.
Do we all agree to that? Who doesn't? Okay, Nelson, defend yourself.
Well,
Do you want anatomical? He might be right. I don't know. I'm not the judge now.
I think the configuration of the fracture compressing will be difficult. So I'd rather go for relative stability to achieve just alignment.
Because
straight.
it's difficult.
I think
If it was easy, would you still want relative stability or absolute stability? I don't know.
it's not a joint, so there's no aim for have absolute reduction, anatomical reduction.
Okay, anyone else who agrees with Nelson? Who agrees with Nelson?
I agree with Nelson.
Okay.
yes.
I think the primary aim here would to obtain as best a closed reduction as possible, and to maintain or restore the length axis rotation of the long bone,
Great.
but that we don't need to go, as Nelson said, for anatomic reduction and absolute stability. We might be able to.
Why is that? What fraction in that zone would you aim for anatomical reduction? Or there's no fraction?
It's something extending into the knee joint.
Okay. Agreed. So what type of stability would you like?
So, I mean, relative stability with the intramedullary device.
Okay. Anyone else? Can you achieve relative stability with any other way?
You do a bridging plate, but that might. You could do a bridging plate with a minimally invasive technique
Yeah.
and take the soft tissue around the fracture, but we get earlier weight bearing and better construct with the nail.
So, George, you said you want anatomical reduction
If I can, yeah.
and absolute stability, and then you said a nail, right?
So I said no, I said two options, nail or blade.
Yeah. So can you get anatomical reduction, absolute stability, and with a nail?
nail, no. Maybe only if I would be lucky.
Okay. So, okay. So let's say that there's no nail available. Okay, for some reason.
So if we don't have nails, then I will go for plating with screws.
Okay.
For
Let's
this
say.
one, I would like to have the lateral position, I believe, for me, and lateral incision. We use a list blade that will be long.
Okay. So, you said before that if you have a nail, you said antegrade or retrograde.
Retrograde.
Why?
Because the fracture site is on the distal third
Yeah.
of the shaft, and my basic fixation will be in the distal part with two screws, and that is the basic use for lever.
Anyone disagree with that, or would do something else? Nobody would consider like Royal like faith in the system.
I guess there's an argument because there's potential distal extension on the X-ray.
Let's say there's no distal extension. It's what you see. Okay.
Antegrade's an option as well, but
What's the problem with retrograde?
Knee pain.
Knee pain. And the problem with antegrade?
Hip pain.
AVN.
Alien.
Sure.
No, no, you have to really miss the target, right? So, so knee pain with retrograde, hip pain with antegrade. What's the reason for the knee pain, do you think, with retrograde? What?
Long
What's the main reason?
There's a patellar plexus in there.
Yeah.
Patellar plexus.
Yeah,
Is there any actual damage that's being?
On the surface of the patella, and maybe if the nail is protruding into the
Well,
joint.
it's not a suprapatellar tibia nail, so it's a retrograde femoral nail.
Yeah,
So
but we
you're
still
not
drill,
really.
drilling underneath the patella.
No, the patella is.
No, sorry, no. A protruding nail tip and then debris from the drilling.
If the nail is not protruding, can you still have knee pain? So if you put the nail in the right position, can you avoid knee pain?
Fat what is it when you pain?
You can't guarantee.
So you might have pain even if the nail is in the right position.
you still build some articular cartilage, don't you?
So where then is the nail going in when it's retrograde? Through
Through articular cartilage.
the joint, right?
Yeah, yeah.
It's not weight bearing, but still intra-articular, right? So you get knee pain because of that, and maybe because of reasons we don't know. Why do you get hip pain?
Abductor.
Abductors.
Okay. So you consider that. Which one of the two do you think would lead to a more disabling situation, like
Knee pain.
So yes, I mean we love retrograde nails here, and we love doing them because they're easy. Okay, mainly because of that. They're quick, but they have complications, right? And it's a femoral fracture. I mean, still the golden standard is an antegrade nail, unless it's a distal third involving maybe the joint. Okay. So let's say this guy agreed with Mamarellis. Okay, and reduced everything anatomically. Okay. So he got an anatomical reduction. You can see the various instruments there. So if he did that, let's say he did that, okay, and he managed to make it look like an intact femur. So what next? He's done you a favor. So what's next?
Then I would choose a plate.
But you said a nail at the beginning, right?
No, I said an option.
Okay. So what kind of plate would you do? Then
So we use a long list plate.
you mean
On the NC.
amiibo?
Yes.
Okay.
Because there was an extension that was going to like this that just said this.
So nice technique, respecting the soft tissues. Okay, and he got this. Who will answer the question?
So they've gone for absolute reduction, so absolute stability in the fracture with an anatomic reduction, and they've used a neutralization plate to prevent against rotational force.
So these are lax screws, right?
Yeah.
So that's why there's no dogma. So the same fracture, some people treat it one way, some people treat it another way. The point is, if you get this reduction and the lag screws, what kind of healing do you expect?
Primary growth.
Primary healing, so you won't see. So what's the disadvantage of this method, let's say, and this implant?
Takes longer, it is weaker.
And do you know when
We
it's
can't,
healed?
yeah, we don't know when it's healed.
So easy. And can you wait there from the beginning?
Yeah.
Okay, but because the surfaces are massive, okay, the complex surface, you can also go for relative stability and still split the strength between many, like a large surface area and get, so there's no dogma, you can treat the same fracture with two ways, as long as you know why you're doing it, right? Let me check something else.
That's there's even a contradiction in the technique because screws for absolute reduction and the plate is semi-rigid.
Yeah, the plate is neutralization, is rigid.
So I was told you can either use one, either rigid fixation or
It's the same principle we apply to a Weber B fracture. You put a lag screw to compress it, so you got absolute stability, but you want to protect it with that neutralization plate. Because the lag screw is a fixation, it's not a plate. But because you don't want to lose it, because it's a point fixation, you hold it together.
So are you saying that it's alright to mix rigid and semi-rigid techniques together?
I don't think they're mixed.
So the whole thing is semi-rigid.
Oh, it's rigid, I think.
It's
Because
rigid.
you did the lag screws first, so it's rigid. They're not position screws, they're lag screws. So you clamp it and you fix it, so it's fixed under compression, and you protect this result with a neutralization plate. If you do the plate first and lock the screws, and then try and do screws, that's mixing the principles, because you fixed it in, you breathed it and you locked it there, now you're trying to hold it together without reducing it.
So it's considered rigid fixation.
So yes, so I think your first, how can I say, your first fixation that achieves the stability you want is the mode of fixation. And then how you neutralize it, it's up to you. You can put a plaster, you can put an X-fix, you can put a, hypothetically. But the basic principle for lag screws is that you protect them with a neutralization plate because they're not enough on their own. Some people say that in the fibula you can just do lag screws, for example. It's fine, as long as you believe that they will stay there. It's the compression that makes it rigid, not the implant. Let's do one more, and we can go to the last place. So, similar fracture, but the patient is porotic, she's diabetic, she's old, there's a closed injury, isolated, neurovascular intact. What's the difference between this injury and the previous one, in terms of mechanism?
It's a low energy.
Low energy. So you expect less soft tissue trauma. Okay, so how would you approach that? Again, go for type of reduction, type of stability, and implants.
So this is extra-articular distal femur fracture in a elderly patient. My principles looking at the fracture pattern would be to achieve relative stability and restore length, alignment, and rotation. The difference in this and the last case for me is the age of the patient with some of the comorbidities. I think our primary aim here would be to restore early mobility, and as such, I'd prefer to go for a rigid intermedullary device that could get her weight bearing as soon as possible, as well as having minimally invasive soft tissue
Great.
insult.
Come on, do it. Come on, look, the difficult part is in front of you. The easy part, you have to find what bone it is. I think you can do that.
3, 2,
Come on, what bone is it?
3,
So yeah,
What part of the bone is it?
this apart, so 3, and then
Do you know how to measure and how to judge if it's you know, it's not straightforward whether it's mid-shaft or distal? Do you know how to measure and what to measure? Does anyone know?
Yeah, it's from the physis, you do a square, and basically what is includes in that square from the physis.
Show me.
So, if we think that the physis was around here, we measure a square that is going to be exactly the same, and anything that includes in that square is going to
So,
be the
wait,
metaphysis.
draw me the square again.
So if we know that this, like if the physis was here around, so we take this and we make a square.
Yeah. You're almost there, but does this mean that this is not in the femur?
No, this is basically this is the metaphysis, this is the physis, and this is the epiphysis.
So
So right now in the adult, it's just the distal femur articular surface.
So the AO classification splits it into proximal, mid, shaft, and distal. So how do you? What does this square contain? The
So
distal or
anything that is metaphyseal is distal. So anything that will be from the square and distal.
So the square is up here. So this is metaphyseal. Okay. You're almost there. So you.
There's a square containing the square which each side equal to the maximum width of the distal femur.
Okay.
In,
So the maximum
starting
width-
at the articular surface. Upwards.
Absolutely. So the maximum width, which is here, is the side of the square. The one side of the square is at the joint, and then you draw a square. So that's the distal femur. Okay, that's the joint fragment. So what is this now that you know?
This is to get 33B1.
So if you draw that square, so where does the fracture start? It's here, right? Maybe here. No. Yes, it's here.
32.5.
Agree. Okay, anyway. I said 2. Okay. So it's 2. And then?
B1.
Is it a B?
2.
What's the difference between a B and an A?
The wedge.
There's a butterfly, right? Is there a butterfly in this one?
CT scan.
Okay. What's the difference between 1 and 2? I mean, I know I'm getting exhausted, but that's how you remember it. What's the difference between 1
A
and
is spiral, B is oblique. A is lower and 1 is spiral and 2 is oblique. Yeah.
And 3?
3 is a transfer.
Between 2 and 3, what's the difference?
It's the energy. It's bending that.
Okay, what's the difference in the line? When does the transverse become oblique?
30 degrees.
Huh?
30 degrees?
30 degrees.
Yeah. Anyway, it's a 2. Okay. But if you can justify your answer, you can say whatever you want. But that's the way to think about it. Okay. Anyway, she's diabetic, she's old, and she has no other injuries, closed injury, and you said you wanted to do get her walking. Anyone else? Any disagreement? Then why did they do this?
I would do plate.
I'm very annoyed that they did this.
I would like plate.
Do you like this plate then?
They did this to treat the X-ray.
Sorry?
They did this to treat the X-ray. To make a nice looking X-ray.
So this is
Something
an
like
era
you
when
do
they were,
nice with it.
when unicortical locky screws were supposed to be magic. Anyway, what did they not do a nail? There must be a reason. So in porotic bone, you're a bit careful with the nails, because the only thing that's holding the nail to the bone is like a single screw, or maybe two screws. It's not very robust. But now we can use blades in this, so we have options. How about the unicortical screws at the top? Really? So can you weight bear this patient? No. Anyway, they did it. It's for debate. I disagree. But what do you see happening to you? How is this bone trying to heal? So there is movement, right? They achieve relative stability. Okay, they had surfaces, as opposed to the previous one, that they treated with absolute stability. So both ways work if you do them right. They were lucky, I think, that it did not fall apart and healed. But it healed with callus. Okay, you can see that. It doesn't mean that this is the right thing to do, right? It's just justifying your answers. So if you want to defend this, how would you defend it? Let's say you did it and you're in court. Why did you do this and not a nail? George said, because a nail in porotic bone is not such a good idea.
We created a bridging construct with enough movement that it healed. She survived. She was only 70. She only had 2 minor comorbidities.
Exactly, they are mine.
So there are arguments for both sides. Okay, very rarely there's a golden solution for trauma. Okay, so I mean, honestly, I'm ready to stop if you want. Unless you want to do more, I don't mind. What do you want? One more. Let's do something with a complication. Okay? Okay, so most of the story is with you now. Who didn't talk? Oh, sure. You've done the exam, right? Come on, show us what you learned.
This is mid-distal tibial calf fracture. One of the views it looks like it could be extending into the joint, so I would want a CT scan. But again, I approach the patient according to ATLS principles and A&E.
Is it common that they would extend the joint?
No, always, but we have seen it.
Let's say that this fracture was spiral, okay, proper spiral. This is something between oblique and spiral, right? But let's say it was spiral.
Yeah.
And we agree that it's distal third, right?
Okay.
I'm not saying that 3 are going to be, it's distal third tibia if you split it in 3. So, distal third spiral fractures, is it common or uncommon to extend it to the joint?
Uncommon.
Any disagreement?
It's up to 50%.
If you did an MRI scan or a CT scan in every patient with a distal third tibia fracture, what do you think the percentage is? 50? 80% that there's an extension into this. 80. Doesn't mean that it's something that is placed and it's fixing and it will fall apart or whatever. But they did the study, it's not my opinion, and they saw that it's an 80% chance that there's a crack going down to the joint. It will probably not affect treatment most of the times, but you need to know, right? So, high suspicion to ask for a CT scan. Let's say they didn't do a CT scan and you have this fracture, what do you want to do?
Okay. So my treatment aim, well, so yes, according to ATLS principles, this is a closed injury, so I'm not worried about treating the
isolated vascular tag, ATLS, okay, let's go to the...
So, principles of treatment, I would go for operative management, I would go for early mobilization. This is an unstable injury, I want to go for relative stability, restore the length, rotation, angulation of the tibia. So in my hands, I would use an intramedullary nail.
Perfect.
I would use a suprapatellar nail because it's a distal third. My understanding is the preference to control more rotations to use perhaps 3 distal officers rather than 2.
Anyone who disagrees with anything Sharon said?
You can manage it equally well with an infrapatellar nail for that matter. I mean,
Okay.
it doesn't have to be a suprapatellar.
Mr. After, do you remember?
Yeah, I'm more used to infrapatellar nails and I still prefer them. But I think for this fracture, it doesn't make a difference whether it's an infrapatellar or suprapatellar. Your consideration is what you're more comfortable with and how much you think a suprapatellar nail actually damages the PFJ. Because with the best will in the world, no matter what you say, if you're not absolutely super careful with a suprapatellar entry, you will take out some of the cartilage underneath the patella. And if you can be absolutely certain, then you can say maybe not. Otherwise, for me, it's infrapatellar because unless it's apex anterior, I don't think there's any hard indication for suprapatellar.
Some say yeah, but even the pressure from the jig, even if you use the nice plastic sleeve, just the pressure will damage the cartilage.
Yeah, so for me, this is an infrapatellar nail, early mobilization, exactly the same
yeah,
for distal space.
so you mentioned it, but what would you do a suprapatellar nail? What would be your indication for a suprapatellar nail?
Proximal third
Proximal.
fracture.
Apex anterior, right?
Apex
Apex anterior.
So, any other way you can achieve the restoration of axis length, rotation, and achieve relative stability?
Yeah, external.
A bridge plate, minimally invasive bridge plate.
Any other way?
Frame.
An external fixator.
Yeah, frame of the frame. So, they did that. So, they did what you said.
They didn't reduce it, they didn't do it.
No, they didn't do exactly what you said. So they did 3 screws, they used a nail, let's say it's suprapatellar, but they did not reduce it, right? So yeah, you cannot go to fixation before you get the reduction you're aiming for.
But there's also a concern with a proximal fibular fracture, right? So if there's a concern with the syndesmosis, the distal tibial fibular joint, then there is something that is sufficient.
Yeah, it shows you that there's something more going on than a simple tibial fracture, right? So, what does this injury tell you? The proximal fibular fracture. What type of injury is this? What's the mechanism of injury? Rotation, right? So there are injuries that you cannot see. There are ligaments, structures that are injured but you cannot see in the X-ray. But there is a hint. So force has gone from there up to there, right? And possibly even more distant. So, what's the deformity here?
Sorry, Vris.
It's varus.
Yes.
Is this how they commonly displace the distal tibial fractures? What do you think? They usually go into valgus, right? But this one went to varus. So what could they have done to avoid this? Let's say you're in theater and before you do your distal locking, you see the fracture looking like that.
Blocking.
Take it out, reduce it properly, we don't take it out.
Blocking should be bad. Go on.
So,
Take it out, but when you take it out, you're going to have a...
Reduce it properly, the assistant or the main surgeon holds the distal fragment properly and the other...
let's say you try this, reduce it, when you put the nail in, it goes back into this position, which is what will happen. Okay.
Where are the roll blockers?
You can use quick stab incisions and use a clamp to hold the fracture, 1. 2, if it's still not possible, you can use polar screws or at least polar
Where would you put your polar screws?
So entropy for the varus deformity, it'd be somewhere here, anteroposterior.
Okay. If you put this screw and you see it, so your nail will go there, right?
Yeah.
If it goes here, so it goes where you want it,
Yeah.
but then it goes there.
So we put another one down there.
2 screws.
So it depends on us. So I think if during intraoperatively the only deformity we are encountering persistently is the varus,
Yeah.
1 polar screw here should be able to do the trick. It will prevent it from lifting. Or we can add another one here.
On the other side.
Yeah. So to create a channel in which the nail will go and it will not go anywhere else.
Do you guys know that there's a nice rule? Do you know which side of the nail you put the screws according to the deformity?
The concave side.
Where you don't want the nail to go.
That's your daily goal.
Where you don't want the nail to go. That's a very weird. Anyway, concave and convex to me, it's the most confusing thing thought you can have when you're doing an operation, right? even if you get it right here, I'm in doubt that you get it right here. Where you don't want the nail to go is a very nice way of thinking it. There's a nice paper that's published just for this, and it's the most helpful for me. So, assume that you want to correct it with your hands. Okay, how would you put your hands? Show me. Can you get up and show me? With your thumbs and index fingers.
Hoping to go this way.
Okay? So, you just hold it there. No, you have the shadow, it's nice. So this is close, this is close. One should be here, right? Okay, good. So, you want to do this with your hands, so you put the polar screws on the opposite side of your fingers.
Oh lordy.
I'm with you, dude.
Look at that. It's gonna fall.
That's too much.
So you want to do this, right?
You don't want to take photos.
So you put your polar screws there, and these ones you put on here. Think about it.
What if you reduce it from the other side?
It depends.
It's the reverse thumb rule, but yes, always. If you think that you're going to
The reverse.
you put the polar screws on the other side of your fingers.
Your
So
thumb.
reverse thumb, opposite thumb.
Opposite thumb.
Opposite the thumb.
So how would you fix this now?
Little finger.
What are you going to do? Let's say the day after the operation, we see this in the trauma meeting, and Mr. Bates freaks out. And
Mr. blows it out.
So, even Mr. Dimasio doesn't like it. So what do we do? So option A, let it heal and revise it. Option 2, take the patient back to theater and change and do something. And option 3, take the patient to theater and use a different way of fixing it. So, let it heal and treat the complication. Revise the nail or revise the method. So who's for leaving it there?
What was the difference in revising the nail and the method, sorry?
Put the plate.
Well, you could put a plate on instead of a nail.
Plate, a frame,
Okay,
whatever.
okay.
Depends on patient comorbidity and what patient has.
Let's
If there
say
is
there's no
nothing else,
restriction,
then you
you
then
can
go
do whatever
with
you
it.
want.
45-year-old.
Fine, then I would then do that.
So-
I would take it to theater.
If you let it heal like that, what's the problem called? Okay. What's the problem called? Like mal?
Malunion
So
gravis.
malunion. What do you have to do to correct a malunion?
Osteotomy, take the metal out.
Okay. Would anyone go for this option?
No.
Okay. Revise the nail or revise the method?
Where's the nail?
You could try revising the nail, but you might have difficulties where you create your channel instead of bone.
Revise the nail and consent the patient for something else as well? Maybe, keep the options open. What would be the other option?
Plate. No.
Frame.
Later. Frame.
Or frame. Whatever. That's when you have a chat with the patient. I mean, you show them a frame, it doesn't mean it's going to be on for a few months. So
I see where you're going with this.
reduce it.
We're not reducing it. So you jack it up
Yeah.
by 6 inches. You
Yeah.
put a bowler hoop, or have a bowler hoop, you get a bloody great down pin, you stick it in the heel, you pull like hell,
Yeah.
because spinal fractures are inherently stable.
When they reduce.
Axial traction is properly applied, because they always reduce.
And then?
Perkins rule, published 1964.
When?
1964.
And okay, and then I agree. And then when you put the nail in, it's going to go back where it was.
Not if you put your ball.
Not if you put your block. Okay, remember?
So they did block it, they did their
I did one.
the channel.
Here's the only way.
Okay, and if you see that they noticed an interarticular fragment and they fixed it before they did that. So, nail is back, going the right place.
It's doing the same thing.
Did you see that they added locking screws? Did you see that in the end they put the screws on the other side of my... Yeah, one there, one there.
And they went
Really,
to
it works.
and then.
Do we like it?
Now they've changed the screw, right?
Yeah. And the leg is longer now.
Screws bending.
Yeah.
Perfect.
Sure,
It's fine.
Effective when it's actually pressing against them.
I have a nice slide here. I don't know what it's talking about. Yeah, it's the what kind of deformity you get according to where the fracture is. Okay, can you see that?
What's anti-curvature? I know. I'm just saying.
It's a rhetorical question. So you can see that with proximal fractions says that they tend to be larger and distant values. I don't know why this is right because they all want to be values, right? Anyway, that's it.
It's like a chronicle illness.
That's a take-home message. We have to display that. So yes, complications. Sometimes they need to be addressed quickly, sooner rather than later.
Alex, for plumbers and electricians and
People who
fervent praying
4 stars.
do you consider avoiding the knee?
So the funny thing is that the rates of knee pain when you do nails are not significantly different. I'm talking about anterior knee pain, not the intra-articular pain, okay, not BFJ pain. Anterior knee pain are almost the same as infrapatella, suprapatella, and I think even between medial parapatella or transpatella.
Is your question about retrograde versus antegrade rather than?
No, in fact, I'm thinking about having a plate rather than using a nail. If to avoid the knee, if I'm a plumber or an electrician, and I want to kneel, would you consider using a plate initially?
So, to our professional like that, because I've thought of this problem, I would strongly recommend a frame. It's very difficult when you have it on, but it should leave you with absolutely no problems when you remove it, especially if it's just wires. I know it's a pain, but if you know that it's a good healer,
yeah, and you want to be back to work, and you can be, you've got a nail in there. It's amazing what they'll put up with on their side. And they won't moan about it.
they don't want about losing money. Yes, I've said it often. I would still, for tibia fracture, prefer nails unless there's a reason.
So you try to avoid the anterolateral pain?
For this one, I think that's the distance. I don't see the benefit. If it's very distant, yes, but if it's at that level, it won't allow weight bearing. It will only allow for ankle range of movement. That's a big benefit. But the rest, okay, fine.
They have the other side.
People would say that it's they would do a medial plate. AOs or like it a lot, but I hate. Nico medial plate, yes. That's stronger than lateral plate if you want, because you can. It's stronger, but it's very common. You need to create a pocket. You need to make an anterior medial incision and slide the plate so your sutures are not on the plate. But again, if it's a fat patient, I would do it. But if it's a thin patient, I won't.
Alex, thank you so much. Thank you very much. Stop talking now.